Cool. 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 Okay. So now we are live and we're today our study session is talking about coma and brain herniation. So we are currently listening to a podcast from the Anatomy for Emergency Medicine Brain Herniation. So I'm going to go ahead and share our screen. I'm here with Sion. And we're just, go ahead. Yeah, do you want to introduce yourself if you like?
Well, sure. Hi, everyone. Name is Sion Hills, Jamaican medical student, and I'm here with Doc to discuss, as she mentioned earlier, uncle herniations or herniations overall. Yeah.
Awesome. And for those of you who don't know me, my name is Dr. Ighodaro. I'm currently a third-year neurology resident, neuroscientist, health disparities researcher, and founder and president of ZIGBE. ZIGBE is a nonprofit where our goal is to eliminate health disparities in the Black community through education, empowerment, and advocacy. And part of one of the programs we're doing as part of the nonprofit is creating neurological study groups that I launched 2 weeks ago. And so that's what the study group is about. And we've had over 150 neurologists and medical students across the world sign up. And today we're going to be focusing on not intracranial hemorrhage. We're going to be focusing on coma, TOS patients, and brain herniation. This information is for educational purposes only. It should not be used for medical diagnoses. And if anyone who's listening has a concern for medical illness, they should contact their licensed primary professional provider. So with that, I'll share my screen and we will get back to talking about intracranial coma, TOS exam, and brain herniation. Can you see my screen, Sion?
Yes.
Awesome. So we're just going to start it over and go from there.
Hello, welcome back to the Anatomy for Emergency Medicine. This is starting today's case on a little bit of trauma. We have a young male who's been involved in a significant car accident. He's been ejected from the vehicle right through the windshield. He's found lying on the tarmac. GCS will look at the scene because it's really easy for yourselves.
Want to tell us again what GCS, the component of the GCS exam is?
Sure. So GCS is the Glasgow Coma Scale, one which is used to measure a patient's level of consciousness. It involves a patient's best motor response, patient's best verbal response, and a patient's best eye response, where the best eye response is marked out of 4, graded out of 4. Best verbal response is graded out of 5, and best motor response out of 6. The minimum score you can attain from a Glasgow Coma Scale or GCS is 3, and a maximum of 15, which is best.
Awesome. And I'm a visual learner, so I'm going to pull up GCS just because to help with, memorizing and whatnot. So let me just pull that up. GCS score. Well, quickly. This is my go-to image for the GCS. And one person taught me how to remember it. You remembered it pretty well without any issues. But for those people who are listening, an easy way to remember it is, 6, 5, 4, with 4 being the highest number you can get is 4 with the eye response, because you have 2 eyes, and if you wear glasses, 2 times 2 is 4. And then with the motor, I just remember eyes, mouth. You have eyes, mouth, hands, and then it kind of goes from order. Your eyes are in the top, then your mouth is in the middle, and then your hands and feet are at the bottom. So if you remember that the eyes is 2 times 2 is 4, then next comes the mouth, which is 5, and then motor 6. So 4, 5, 6. Actually, a previous study group member, physician, I think she was the one that taught me that trick, or maybe a medical student, but can't remember. But either way, that's how I remember it now, because I used to always have issues remembering the GCS. So there you go. Nice work. We'll get back to the podcast.
He gets brought to CT scanner. He's got a horrible crack in skull at the side, and on the brain windows, he's got blood. He's got a tight looking brain, and their ventricles have disappeared. He's certainly got huge hematosis next to him as well. Okay, so this is a guy who's in trouble. Okay, he's got a severe traumatic brain injury. You get him back from the CT scanner, and you're doing all these your observations, and you check.
Oh, Sion, would you like to read the CT scan for us again? Now that we're recording.
You could try.
And remember, so pretend you're in the ward, and the attending pulls up the CT scan. So you want to tell me, is the CT scan an MRI? What kind of imaging modality it is? Is it what organ is being shown? Is it with or without contrast? What's the orientation? And then go from there.
Okay, so this is projected on the screen is a non-contrast CT scan of a patient's head, specifically an axial cut. Of note in terms of reporting anteriorly and on the right. I think a hyperdense area collection on the whole, on that side of the head, with what appears to be a depressed portion of the skull in that region, and a hyperdense area immediately beneath that, behind or posterior to the frontal bone, is my description.
You final answer?
Yeah.
So what do you think? So then what would be on your differential based on what you described?
Okay. Considering the history at traumatic injuries, I'd say blood and subcutaneous emphysema possibly on the outside there.
Yeah. So
depressed skull fracture.
Very good. So now that I figured out how to annotate, take this to the next level. So I agree. This is a CT head without contrast, because I'm not really seeing a whole lot of blood vessels that are highlighted. But it's kind of hard to tell unless we have like a sagittal view. But usually in most cases in the acute setting, we're doing CT
contrast
without contrast, because the main reason to get a CT head without contrast in the head injury or on a neurological basis is to look for bleeding. Right. So as we talked about a couple of days ago, what's white on CT scan?
What appears light is bone and blood and any calcified areas.
Yeah, very good. So we know this skull is this white region here, outside is skull. And then we see here some hyperdense regions.
Right.
And then we also see this area too that's hyperdense. Right. And then this area here is also hyperdense. So we have a abnormal CT scan of the head, axial cut without contrast. Right. It looks to be there are large hyperdense region. What side of the brain is this?
That's on the right side of the patient's brain, anteriorly, or the front.
Yeah, very good. So that's something else you can add to your description. You can say on the right side, we see a hyperdense collection of what appears to be blood. And what kind of pattern do you think this is from a bleeding standpoint?
Oh, in terms of an epidural collection.
Yeah, because it has that kind of like it's like pushing against the the brain parenchyma, it's not crossing, the suture
The suture
line.
lines, right?
Yeah, so that's like pathognomonic for epidural
Epidural
hematoma. So I
hemorrhage.
agree with you. So this looks like epidural hematoma. And I also see here, so along with this big collection, I also see some discrete hyperdense regions, along the brain parenchyma on the left side and also on the right side as well. So this could represent bleeding, would be my guess. Or,
Okay.
maybe this could be like, how the core plexus can also be a bit
Right. That's,
calcified.
yeah.
So maybe that's what's going on here. But here, this is definitely not an area that's typically calcified.
Right.
So I would definitely say at least here,
Could
I
be
would
some
suspect, yeah. And then what else someone use a different color. So now that we've talked about what we see, what do you think is going on here?
I think that's a depressed skull fracture. So yeah, of the period of the skull. Yeah.
You know what I think? I don't know. It's kind of, maybe there's probably some skull fracture going on, but I do suspect that this person probably fell. And I think this just might be an area of, what did they call it? Swelling. What's it called? Well, we just call it just swelling of the soft tissue. Oh, there's a word for it. I can't recall it at the tip of my tongue. But yeah, is there just, is there skull fracture displacement? It's hard for me to tell, but this just looks like swelling due to this epidural hematoma on the right side. So that's good. So what else are you seeing? Where's the ventricles?
Right. Not very clear, but I'm seeing areas that could, be the ventricles, where the ventricles are, so which you're highlighting right now.
Yeah, are those normal sizes?
No, looks much smaller here. Much smaller.
So why do you think it's small?
Could be in this patient, I'd say possibly because of the mass effect of the epidural hematoma, as well as possibly some amount of cerebral edema, but not too sure about the cerebral edema.
No, I completely agree with you. I think there's brain swelling because the ventricles are really small, and that's concerning for maybe some obstruction of the ventricles. So we have, we talked about the epidural hematoma that's hyperdense. There's also some evidence of brain swelling because the sulci, the sulci are
visible.
Exactly. So that's also the evidence of brain swelling. And then your ventricles are not as pronounced too. So that's also the evidence of brain swelling. What else? Another thing about midline shift, there's probably also some evidence of midline shift as well. Because here, if you go from anterior to posterior with this straight line, the septum pellucidum, is that the word?
Where?
Let me give me 1 second.
No problem.
These pupils. And you notice when you
Oh
get back,
man, we have such a beautiful drawing. So I'll clear that later. Let's see, measuring midline shift on CT head. So what radiologists do is that they make a straight line through the septum pellucidum where it should be, and then that's how they measure midline shift. So if you take a look at this image, I'm gonna blow this one up. Oh, let me just clear this. Okay, here we go. I love reading images. So you see what they did here? So they go from the interior to the posterior side,
Right.
and then they draw a straight line where I think the septum pellucidum should be, and then they, they can count in centimeters how far away is the septum pellucidum from midline, and then that's how you calculate midline shift.
Okay.
So if we go back to this image,
In your observations, you check these pupils, and you notice when you get back that he's being the pupil on the right hand side.
so yeah, if you kind of draw a straight line, and then if you draw it to where the septum pellucidum is, that the length perpendicular kind of gives you how much midline shift there is.
Okay.
Does that make sense?
Yes, it does. Perfect sense. Yes, it does.
Does that make sense?
Yes, yes, it does. Yes, it
Calling
does.
from Windows Q4 J81TB.
Are you hearing me?
Yeah, I can hear you
Okay.
now.
Okay.
Cool. So is this good or bad?
Bad.
Okay, so here's would you expect to see on exam with this patient based on the stuff we've talked about previously? You have a patient, we know their GCS is low at the scene. Looks like they may have had a traumatic brain injury resulting in epidural hematoma. They have diffuse, discrete hemorrhages along with the epidural hematoma. They have midline shift. They have mass effect. They have edema and swelling. So do you think this patient would be talkative?
No, I think this patient would have an decreased level of consciousness, or patient could even be unconscious.
Yeah, I agree. I completely agree. So let's see what they have to say.
You get them back from CT scanner, and you're doing all these your observations, and you check these pupils, and you notice when you get back that he's being the pupil on the right hand side, so he's got a dilated pupil. So this is
Okay, so now this patient has a dilated pupil, blown pupil on the right-hand side.
Right.
So previously, when we were talking about the neuro ICU exam, if your pupils, typically your pupils are round, equal, and reactive. And if they're not, then we have to figure out, well, what's going on? So they shine a light on this side and no reactivity. Shine a light here on the, left side, looks like it's normal, but on the right side, there's no light response.
Right.
So the light response is the cranial nerve occipital, or not occipital, cranial nerve 2 and 3 are responsible for pupillary response.
Yeah, right.
So if this person has a blown pupil on the right, that means that they're what's it called? Their optic nerve 2 is out, which is the afferent nerve.
But in this
Right.
patient, wouldn't it be mostly the oculomotor division, which is the motor response, since possibly that's the one that is affected in terms of compression, if this patient
Yeah.
has increased ICP, increased
Definitely.
intracranial pressure, that is.
Yeah, this patient definitely does have increased ICP evidence with the brain swelling and the edema and the mass effect, midline shift, and the compressed ventricles. So when you have a patient that has a blown pupil, cranial nerve, we're thinking cranial 2, cranial nerve 3, what part of the midbrain is that?
Oh, well, cranial nerve 2 is not a part of the midbrain, if I recall correctly, but cranial nerve 3 is at the level of the superior colliculus or superior colliculi in the midbrain. Yeah. But cranial nerve 2 Yeah, it's mostly afferent, not really a midbrain nerve, mostly related to the frontal.
Oh, I think I gave you the answer. Sorry, I wanted to ask what part of the brainstem is cranial nerve 2 and 3. Sorry.
Yeah, it's okay, midbrain.
Yes, fantastic. So that's not good because I think that's where the reticular activating system is as well. Let's look. Let me look. Do you know offhand?
Thing that we're looking for when we do.
I'm sorry?
Do you know offhand where the reticular activating system? I think it's in the midbrain.
I think it spans the entire length of the brainstem, or almost. Excuse me.
We always talk about some tract. This might be more complicated than I. Huh. Throughout the brainstem. Oh, yeah. Okay. So it looks like it's in different. Looks like it's in different parts of the brainstem. Okay, somewhere in the brainstem. I think it's midbrain, but it might be still debated. Okay. Interesting. Cool, cool. Let us continue.
Your observations. So what's happened here? Well, this is nice and easy. I mean, this guy's coming. He's having a brain herniation event. He's squeezing his brain like his brain started to tube through the foramen magnum. As the pressure has gone up in the skull, it has to squeeze out somewhere. It squeezes through the brainstem, and that's the end of things, isn't it? Okay. Well, brain herniation is a little bit more complicated than that. There's a few more subtleties to it that might be useful to you. So we're going to try and go through these. Okay. There are three main types to talk about. Okay, there are lots of ways to describe, but three are probably a little bit more relevant and common. First one we're going to talk about is subfalcine herniation. What we mean by this, a falcine refers to the falx, the piece of dura mater underneath, and it's the brain herniating underneath the falx. It forms subfalcine herniation. That's the first one. The second type that you'll hear is what we're called transtentorial. I think that's a bit more descriptive. Where you get herniation across the tentorium cerebelli. Now, sometimes it's called uncal herniation because a bit of the brain that does the herniation is called uncus, but I think transtentorial is a bit more useful, that you know where the actual problem is. That's where you get the really famous sounds, things like the pupil and so on, but we'll get to that in a second. And then thirdly, the other important one is tonsillar herniation. What we're talking about here is the tonsils of the cerebellum squeezing through the foramen magnum, and that tends to be the final point of all these brain herniation syndromes. Okay, so let's start with subfalcine.
I didn't know that. Did he say that the tonsillar herniation is like the worst, or the? I'm gonna read. Did you?
Yeah,
did you hear what
I
he said?
think it is, because that's the one that would compromise brainstem function probably the quickest. Excuse me.
Okay, we already mentioned that the falx that we're referring to here is the sheet of dura mater. Okay, we talked a little bit about it last time. We talked about the size of the sinuses. Okay, the superior and the inferior one. This is a fold of thick dura mater that separates the right and the left hemispheres. You can see it marked on there in red. It's running all the way from the front to the back, separating the two hemispheres. On the MRI that we have, let's see if I can show you see quite nicely in this one. This is a grossly abnormal MRI for lots of reasons I'm not going to go into. Now, you start at the anterior part. Can you see this shiny piece coming into you now? If I run a little bit further, you'll see it running all the way across the back. So that shiny sheet of material will line right in the midline, separating the two hemispheres is the falx that we're referring to, falx cerebri. And when the brain herniates, it's usually the cingulate gyrus of the brain herniates under the falx. And just okay, so as mentioned, the piece of the brain we're interested in is the cingulate gyrus. Don't worry too much about that. It's not that important to you guys. It squeezes underneath the falx cerebri and ends up lying kind of adjacent to the opposite cerebral hemisphere. Okay. So here's an example, more usefully and more relevant of what we see is midline shift. So when you see midline shift on a CT scan, particularly the ventricles, if it's shifted all the way over to another side, that's, you've got subfalcine herniation. Okay, so the single gyrus is looped underneath.
That is really cool. I did not know that. Like the falsy, that I didn't know that at all. That is very interesting. Can you hear me?
Yeah, hearing you clearly.
Oh, can you hear me? Oh, my computer loves that. Act up. Can you hear me now?
Breaking up just a little bit.
Oh, can you hear me now?
Yes, yes, much better.
Isn't that cool? I didn't know that that's why it was called, you know, I'm gonna
Subfalcine.
play it again. Like, that is really cool. I'm gonna play it again.
Squeezing through the foramen magnum, and that tends to be the final point of those great herniations. Okay, so let's start with subfalcine. Okay, we already mentioned that the falx that we're referring to here is the sheet of dura matter. Okay, we talked a little bit about last time. We talked about the sides of the sinuses. Okay, the superior and the inferior one. This is a fold of thick dura matter that separates the right and the left hemispheres. You can see it marked on there in red. It's running all the way from the front to the back and separating the two hemispheres. On the MRI that we have, let's see if I'm going through it, you can see quite nicely in this one. This is a grossly abnormal MRI for lots of reasons I'm not going to go into. Now, if we start at the anterior part, can you see this shiny piece coming into view now? If I run that a bit further, you'll see it running all the way across the back. So that shiny sheet of material lying right in the midline, separating the two hemispheres, is the falx that we're referring to, the falx cerebri. And when the brain herniates, it's usually the singular gyrus. That's a bit of the brain herniates under the falx and just there. Okay, so as mentioned, the piece of the brain we're interested in is the singular gyrus. Don't worry too much about that. It's not that important to you guys. It squeezes underneath the falx cerebri and ends up lying kind of adjacent to the opposite cerebral hemisphere. Okay, so here's an example more usefully and more relevant of what we see is midline shift. So when you see midline shift on a CT scan, particularly the ventricles have been shifted all the way over to another side, that's, you've got subfalcine herniation. Okay, so the single gyrus is looped underneath the falx cerebri and it brought one of the lateral ventricles with it. Okay, to the cortex. So that's what you're seeing when you see a lot of midline shift. You're actually seeing subfalcine herniation. Okay. So you can see it nice and clearly in this one. Here we have nice midline, lateral ventricle, okay. Here we have the two lateral ventricles both sitting left in the midline. Okay, everything shifted well over to the left. Well, that's all right, Andrew. Does any of this really matter then? When you see midline shift all the time, if that's what we mean by herniation, is it important? Well, there are a few things that probably are relevant to it. If you get everything shifted over to the left-hand side, like we have in the CT and the right here, okay, if this all shifts over to the left, you've got to remember that there's some traction on the circle of Willis. This is our famous circle of Willis. So if you get all this pushed over to one side, you're going to get pressure and traction on the circle of Willis. You might get one of the arteries pinched off. A classic one that tends to get pinched off is the anterior cerebral artery. Okay, so not only have you now got a brain injury syndrome, you also may end up with a stroke syndrome in this as well. Okay, these things can happen. It's not inevitable that you get a subfalcine, you get pinching on the cerebral, but it's something that you want to think about if you've got a lot of midline shift. It is important to say, I mean, midline shift doesn't mean the end of the world. It's not quite the same as the tonsil herniation that we talked about. We see patients with midline shift all the time. This CT scan is actually an example of that. This is a large chronic subdural, okay, a couple of weeks old subdural hemorrhage, which has caused midline shift over the left-hand side. This guy was confused, but he was able to talk to you, he was conscious. So midline shift doesn't imply a comatose unconscious patient, okay? But it certainly can progress to the other forms of herniation that we worry about. Okay, let's talk about transtentorial. This is probably, this is where the money is for us. This is where we're going to pick up the signs and maybe even do something about it. There's usually a few clinical signs that will be a giveaway that will help us to actually intervene and do something. One thing you should note as well as diagrams you get across, there can be two-way traffic. You can get herniation of cerebellum into the above the tentorium cerebelli, but most of the time it's going diagonally. So this tentorium we're referring to is the tentorium cerebelli that covers over the posterior cranial fossa. Okay, so it's marked on there. It runs all the way from the occipital bone all the way across, and you have the brainstem tucked into this notch within the tentorium cerebelli. Okay, so it separates cerebellum underneath, cerebral hemispheres on top, and then this big notch in the middle where the brainstem fits through. Same thing, just marked out just actually on the skull. Posterior cranial fossa with anterior middle posterior cranial fossa. Okay, tentorium stretches across there, leaves just enough room for brainstem to squeeze through the foramen magnum. Let's have a look at the MRI scan. It's fairly obvious in this one that we have. Again, this is this ghostly abnormal scan I've been using a few times. I just want to see the tent-shaped structure. See the shiny white bit there, that tent-shaped structure. Okay, it's the cerebellum underneath. So we have the cerebral hemispheres resting on top of the cerebellum. And if we move that forward anteriorly, we should see, yeah. So see here, this is the notch that we saw in the last one with brainstem passing through. Okay. So when we get herniation, we're going to have brain slipping through alongside the brainstem, going through the notch in the tentorium cerebelli. Okay, the signs, why do we see the signs that we see in a tentorial herniation? Okay, it's to do with the structures that are being pressed on. When the brain, when you get transtentorial herniation in the cerebral hemisphere is trying to squeeze through this notch, the things it's going to press on, and the thing that we're looking for is the oculomotor nerve, the third cranial nerve, okay, the one that does most of the eye movements, and is involved in pupillary constriction as well. Okay, so if you put pressure on the oculomotor nerve, if you squeeze brain down beside that, between the midbrain and the pons, you're going to put pressure on the oculomotor nerve. You're going to lose the constriction function of the oculomotor nerve, and your pupil will dilate as a result. Okay. Okay, let's show you on MRI scan. Yeah, this is a reasonable example. So see this large mass effect. We've got midline shift over here. This is the uncus of the brain that is pressing just on the midbrain here and the pons here. Here we have midbrain, here we have pons, and we've got the oculomotor nerve just in front of that. So you're going to get pressure on the oculomotor nerve just at this point. It's also worth noting that you'll get pupillary involvement in a transtentorial herniation before you get motor involvement. There's two real big functions of the third cranial nerve. One is to constrict the pupil, that's the parasympathetic part of it. The other is the motor aspect of it. It does all your eye movements. Okay. So you're likely to get the pupil involvement before you get the classic down and out pupil. And the theory behind all that is that we've got the parasympathetic fibers lying peripherally in the nerve on the outer aspect of the nerve, so they get affected by mass lesions first, whereas the actual somatic motor fibers from within the eye lie more centrally. So you'll get pupil involvement before you get muscle involvement. Same thing would apply in a posterior circulation, posterior communicating aneurysm. That will be the same sign you get. And in fact, if you get it down in a pupil without pupillary dilation, it's more likely to be neuropathy of the actual nerve than a mass lesion. Anyway, let me go on a bit further. What other signs do we get from a transtentorial herniation? Well, the other signs we get are usually motor signs. Now, these can be a bit variable depending what you read. They're not entirely straightforward. You can get ipsilateral with the lesion. You can get contralateral signs, or you can get bilateral signs. I mean, all of those have reasonable anatomic explanations. So the pupil signs are probably more useful as a localizing sign. But that's we look at our MRI here. This is our MRI with the pressure coming down, okay, in the midbrain, and I've just put a little image of the midbrain just on top of it. We're looking at the anterior midbrain. This is thalamus, and this is midbrain, pons, medulla, just here marked out. So the thing that gets pinched with this is you're going to get pressure on the corticospinal tracts. Okay, those are the descending motor fibers carrying all the motor function down to our limbs. These will run down with the corticospinal tracts, okay, and then they will cross over at the lower medulla in an area called the pyramids, if you can remember that from med school all the way back. So if you can imagine, if you're getting pressure on this corticospinal tract, you're getting dysfunction of that, you will then have eventually a contralateral hemiparesis. So if all the pressure is coming from this side, pressure on the midbrain here on the corticospinal tracts, you're going to result in a contralateral hemiparesis, okay. Now, you can get an ipsilateral one, because you can imagine that this part of it, if you're shoving everything across from this side to this side, you can actually cause pressure of the tentorium on this part of the corticospinal tract as well. Sometimes it's called a false localizing sign when you see an ipsilateral hemiplegia with the side of the lesion. So these things are a wee bit stifled. I don't know how much of this is useful clinically. Maybe the pupil is going to be a little bit more useful to us. Finally, we're going to have tonsillar herniation. Okay, now this is a big one. This is what we describe as coning. Goes off in a bad way, then you likely end up dead, or if you're on a ventilator, then this is often one of your final steps towards brain death and you're an organ donor. So this is important. This is kind of a big deal. So here's a bit of a learning point for this. What we'll start with. You've got to be careful in the posterior cranial fossa. This is somewhere you can run a space real fast. Forward, stay alert. You can run out of space real fast. Okay, so a little bit like you get in the Death Star and become a Jedi. Posterior cranial fossa is a tight little space. You get some swelling and some blood in there, and you can get death pretty quick. This is one of the places where, if you have a problem, neurosurgeons actually have much more likely to intervene. You get a hematoma, cerebellum, and the posterior cranial fossa. That's more an indication for neurosurgery. Okay, they'll actually intervene in that, given how tight the space is. Now, part of the reason it's so tight, we've already noted you've got this posterior cranial fossa is squeezed in between the tentorium, okay, and the base of the skull. Okay, so there's not a deal of space in there. Just to highlight it again, okay, tentorium will run separating the cerebral hemispheres. In the notch at the front, you'll have the brainstem running through it, and then you've got the base of the occiput and the foramen magnum just in there. So not a great deal of space if you get a lot of swelling. Okay, so what is the tonsil that we're talking about that's actually doing the herniating? This is a sagittal section through the brainstem and the cerebellum. We have midbrain with the here, palms here, and medulla down here, and then just through really the center of the cerebellum. The cerebellar tonsil is this section of it, okay, and the medial and the inferior section of the cerebellum is referred to as the tonsil. So if you get a herniation of that squeezes through. It's normally just sitting above the foramen magnum. That squeezes through and presses on the medulla. Okay, and the medulla contains important cardiac and respiratory centers. Because those to dysfunction, all of a sudden you lose your cardiac tone, you lose your cardiac output, and you lose your respiratory drive. So you can have a dead patient very, very quickly from that. On the right, we have a little example on MRI of a cerebellar herniation. I've just marked it on there. So this is the level of the foramen magnum. Okay, we have herniation of the cerebellar tonsils through onto the medulla. Okay, medulla then becomes spinal cord as it passes through. So that causes, certainly the pressure on the centers is a big problem, but you're also going to, if you think about all these things, you're also going to get lots of vascular issues as well, or your vertebral arteries have to squeeze in through the foramen magnum as well. So you can sometimes get ischemia, you can sometimes actually get hemorrhage from this as well. So that's why tonsillar herniation is such a big deal. Now, the other thing that you will see it with is Chiari malformation. Now, you might see this in MRI scan reports and various other things. Not all tonsillar herniation is immediately fatal. People with the Chiari malformation are born with their cerebellar tonsils herniated through the foramen magnum. Now that can cause various different problems, and that's a really complicated syndrome I'm not going to get into in the slides. But just be aware that these people have tonsillar herniation, but they're sitting wide awake and talking to you. And this is an example of tonsillar herniation in somebody with a Chiari malformation. Okay. So let's just run through these three, so hopefully they'll stick in your head. We have three main forms of brain herniation that we're interested in. The first one's going to be the subfalcine, okay, where we herniate brain underneath the falx cerebris, usually the cingulate gyrus, squeezes over from, in this case, right to left. Be wary of pinching off the anterior cerebral artery and getting a stroke-like syndrome from that. And we see this on CT scans as a midline shift. Second one you're going to talk about is a transtentorial herniation. We get the brain called uncus, tends to go down the way as well and cerebellum up the ways. This is where you get your traction and pressure on the third cranial nerve. This is where you get ipsilateral pupillary dilation. So that's the sign that we're looking for. If you've got a transtentorial herniation, you want to do something about that quickly, lower the pressure, and get your surgeon involved. Otherwise, you're going to progress towards the third one, the tonsillar herniation. Now, there are motor signs associated with transtentorial herniation. But they're a little bit, let's just say, not that dependable and a bit variable. Last one, tonsillar herniation, where we get cerebellar tonsils, which herniate through the foramen magnum, causing pressure on the cardiac respiratory centers in the medulla, frequently resulting in death very shortly afterwards. Okay, so these are your three main brain herniation syndromes that you want to be thinking about when you're looking after severely head injured patients. Hopefully that's a bit of use to you.
Let me. Oh, how did I say that? Was really good.
Yes, that was
How long I've
really,
been struggling to learn these brain herniations, and that just like whoa, makes so much sense because he tied the anatomy with the clinical presentation and the way that they put the anatomy so like just they spell it out so clearly. It's
right.
wow,
I
I'm
agree.
subscribe to
That
this.
was,
I'm like adding this podcast to my list of neurology podcasts right now. It's really good. What
that
did
was
you
really good.
what did you think, Sion?
I think it was really good. I think it was really well presented and it was really well done.
Yeah, I'm definitely adding this to my list of I'm gonna subscribe to them right now. Give me 1 second.
No problem.
I have a list of podcasts that I like to subscribe to on my iPhone. Really good one. So, what are the three in this from this podcast? What are the three brain herniation syndromes?
Subfalcine, transtentorial or uncal, as well as tonsillar herniation.
Awesome, very good. So, if you're cool with it, what I'm gonna do because I found a handful of really interesting podcasts that kind of help give the basics. So I'm going to find another one
Okay.
and we can listen to that and then talk through it if you like.
That would be great.
Cool. Give me 1 second.
No problem.
Eating it past next months, all these are bouncing back and forth between a few topics. But we're going to have to focus on TBI and culminate with the committee for technical combat casualty care, new TBI protocol that we're working on, project costs working on shortly.
Hey, Sion,
I'm here.
if you come across any other good resources that you find on brain herniation, let me know. Share your screen and then we can see if it's worth listening to or reading more.
All right. Okay, on it.
Cool. So I found this podcast. This one's Case Files in Neurology. I listened to this a while ago and it was really interesting. So I am going to pull it up for us here so we can take a listen and learn from it.
Okay.
Hello, and welcome to Case Files in Neurology, where we share the stories that our patients tell us and the lessons that they teach us. Our host is Dr. Danish Badi, a movement disorders neurologist at the University of Nebraska Medical Center. He is also the director of our International Neurology program. You will hear some amazing stories of courage, mystery, wisdom, and hope from faculty in our department on cases that have stood out so much that they can still recall it. Art of Medicine.
My fourth year of medical school at the University of Michigan, we had really excellent neuroradiologists, and I wanted to spend time with them. I think I may have been with them for somewhere between a month or two, somewhere in that time. And I did neuropathology that year. I did a 10-week experience in Newcastle upon Tyne in England with John Walton and Peter Hudson, and actually a guy who became a friend of mine from Mayo Clinic. And what I really liked was the time I spent in radiology. At the same time, there was a neurosurgery resident. I won't give you his name because this wasn't really such a well done.
Can you hear Seal?
We were doing new ones several times.
Yes, I'm hearing.
Okay.
Sounds a little muffled, but I'm listening and hearing.
Okay, let me see if I can make
When we wanted to
increase the volume.
We would have them sit in a special chair, and there was a little square in the back, about 1 foot square.
Yeah, that's better.
Okay.
That's where we would do the LP in their back, and we would prep them with betadine and then wipe that off with alcohol, and then do the lumbar puncture after getting a consent form. And I think consent forms might have been mostly verbal then, I don't know. They were probably not forms, or maybe they were just a note saying I got it consent, not sure. Anyway, there was one lady that the neurosurgery resident was going to do a lumbar puncture on, and the idea was you would take off about 10 or 15 cc's of spinal fluid, and then we would push in 10 or 15 cc's of air. And we would take out some spinal fluid, and then the air would bubble up, since they were sitting upright, up toward the fourth ventricle. And if you had them just right and you did it slowly, the air would actually get into the fourth ventricle. And then we could then somersault the patient and get the air into the lateral ventricle.
Somersault on a chair or?
In this chair, yeah, this is a chair. Well, in the old days, we used to have them sitting in a wooden chair, and then two of us would pick them up and we would actually somersault them. So there would be, yeah, we would, yeah, well, no, it would be a little chair like this that we're sitting in now,
Okay.
and we would rotate them. I mean, that's what I learned in England, and I think it was one of the early neurosurgeons that found out, I can't remember his name offhand, that in head trauma cases, you could see air in the ventricles in some cases. If the air came in and got into the spinal fluid, and they were, I don't know, moved in different positions, you could actually get air in the lateral ventricles. And they would use that technique then to identify tumors in the brain, in the ventricular system. You know, you can imagine choroid plexus papillomas and other tumors that were obstructing the ventricles now and then. At any rate, that was the whole point of this exercise. So we wanted to see if this lady really did have normal pressure hydrocephalus. I don't know the whole history, but Lance was, excuse me, I gave you his first name, was telling me about the case. And he and I, he was a year senior to me, and he was also from Ohio State University. And I'm from University of Michigan, and we were arch rivals in everything. So we used to not even want to talk to each other. But he was
But he was working at Michigan University.
yes, he was in the Department of Neurosurgery as a neurosurgeon resident. I was in neurology. Maybe he was a couple years older than that. Because I was like 2 years away from being a neurology resident. Anyway, we were doing this rotation, and he was talking to me about how great he was. And he was taking off, like, I think he was filling up. We usually did CSF evaluation when we did that. So we would collect the first tube and send it off to the lab. And I think he was collecting the first tube, and I may have told you this offhand once, but we were both sitting there. He was in the radiology, lead apron kind of thing. And the procedure was obviously supposed to be sterile, and he had gloves on. And all of a sudden, the lady who was facing away from us, and we were talking like this, and he was collecting the fluid, all of a sudden took a really deep breath. And it was something like, and she didn't exhale. And we thought that was kind of strange. So he was sterile. So I went around and I looked at this lady, and both of her pupils.
Not a fan of this podcast.
Admittedly, parts of it I didn't hear because my dogs were behaving pretty badly. So kind of interruptive.
Yeah, no, it's all good. It's not as much learning as the other
Mostly
one.
talking.
Yeah, I'll keep looking for some more resources for us. I'm a big podcast person, so that's why my go-to, at least to like get a big picture, is podcasts, and then after that, then read articles and textbooks and stuff.
All right.
So let me keep searching.
Is it at like you find your podcast from like a Google search or?
Actually, it's on Apple. So what I do is I go,
Okay.
So Apple has like a podcast app.
Right.
So one cool thing about it is that I just type in, for example, I typed in brain herniation, and it will search all of the podcasts that have the word brain herniation in them.
Okay.
And that's how I select which ones to listen to. And, I look through the names and, who's producing it. Is it coming from a legit resource? And that's how I choose the ones to listen to.
Okay.
Unfortunately, there's not many podcasts on brain herniations, but
MRI, and ultrasound. Maybe it
This might be something, let me share my screen with you. This might be interesting. So I found this YouTube video that published in 2019, that talks about brain herniation. So let's see if this is a good resource or not. Because it's an hour long, I have trained myself to listen to things on 1.5. So let's see how that goes. And let me know if it makes sense or if it's too fast, or let me
Okay,
know what you think.
no problem.
Good afternoon from IMB from Neurosurgical TV. We have the honor today of having the Association of Future African Neurosurgeons. We have Dylan Geofac. He's going to present on cerebral herniation syndromes. And we're grateful for the presence of Ike Cherian, well-known educator from Nepal. Hello, Ike.
Hi there, guys. Good to see you all.
It's a pleasure to have you, Ike. Elric at Harvard, please. I think you know Ike, right? Ike?
Oh, yeah, absolutely. Absolutely, John. Thanks.
I'm just gonna
Okay,
skip.
okay, Dylan.
I'm gonna skip some parts so we just get to the meat.
All right.
Where to go? Where to go? Where Dylan go? Oh, there you go. Okay, Dylan, it's all yours. You're welcome.
Okay, so in order to talk about the cerebral herniation syndromes, we follow this plan, in which we have an introduction, pathophysiological basis of intracranial pressure, the forms, we talk about the forms of brain herniation, and a little bit the management of brain herniation. Next slide, John, please. So, as an introduction, the word herniation has Latin origin, to protrude. So it literally, in Latin origin means protrude. In Greek origin, it's like an offshoot. So basically, when you talk about herniation, it is an abnormal exit of a tissue or an organ through the walls of the cavity in which it normally resides. Next slide, John. So in herniation, we have key factors. We have compartmental pressure, so the pressure in the compartment in which the organ naturally resides. We have the tissue that's protruding and the wall, the opening through which it goes. So generally, herniation is linked to a space conflict with an increase in compartmental pressure in a closed cavity. The next slide, John. So applied to the brain, brain herniation is therefore the displacement of brain tissue from one compartment to another through either the reticular folds, we're talking about the falx cerebri, or the tentorium cerebelli, or the skull openings, precisely the foramen magnum. Next slide, John. So anatomically, talking about the anatomical basis, the cranium is a rigid, inextensible closed box. In the infants and the neonates.
That's a good definition of brain herniation. Hold on, I'm gonna be. This looks like this might be a good presentation. So I'm gonna set up myself so I can be taking notes as it's running. Give me one moment.
No problem.
It looks like we may have another person that's trying to join in, so we'll see if they're able to get connection to join in or not.
Okay.
or the tentorium cerebelli, or the skull openings beside the foramen magnum. Next slide, John. So, anatomically, talking about the anatomical basis, the cranium is a rigid, inextensible closed box. In the infants and the neonates, where the sutures have not yet been completely closed, the cranium can accommodate a certain degree of increase in pressure, but in the adults, it's strictly a rigid and extensible closed box. So this closed box is divided into compartments by two main jural folds. We talk about the falx cerebri, which separates the two cerebral hemispheres, and then the tentorium cerebelli, which separates the cranium into supratentorial space, which contains the cerebral hemispheres, and the infratentorial space, which contains the brainstem and the cerebellum. Next slide, John, please. So talking about the pathophysiological basis, we know from physiology that in the brain we have various compartments. We have the brain volume, or the parenchymal compartment. Here is about the brain tissue. We have the blood volume, be it the arterial blood or the venous blood, and then we have the CSF volume. And according to Monro-Kelly's doctrine, the sum of all of this volume is equal to a constant, such that an increase or an additional volume, the presence of an additional volume causes the...
So see, on one big thing in neuro ICU, one of the fundamental concepts that gets taught over and over and over in the neuro ICU has to do with the Monro-Kelly doctrine. It basically talks about, are you familiar with that?
Yeah, I know what it is, yes.
Oh, okay, great. Cool. Sounds good. Yeah. And just for people who may be listening who don't know, so the Monro-Kelly doctrine is basically that the skull is a fixed space, and within that space contains the brain tissue, the blood volume, and cerebrospinal fluid. So if there's a change in the volume of the CSF, then in order to then, because the skull is a fixed compartment, and that compartment and that space cannot change, then if there's an increase in CSF, then the brain tissue or blood volume has to decrease, or there will result in complications. Again, another thing is, if blood volume increases due to epidural hematoma or brain bleed, like we saw in the previous case, then because it's contained in a fixed space, then the brain tissue will somehow have to decrease, or the CSF will somehow have to decrease. And if it doesn't, then that will lead to increased ICP.
Activation of regulatory mechanisms. These regulatory mechanisms imply the exclusion of the other volumes. As you can see on the tree-level diagram above, we see on the first diagram, we have the CSF volume in yellow, we have the arterial volume in red, and the venous volume in blue, and in the middle, we have the brain volume. So in the second diagram below, we have the addition of the fourth volume, which is a mass of any, it can be of any nature, in purple. And with that addition, we have the exclusion of the CSF volume to the right, and the vascular or blood volume to the left. As the mass increases, we have the continuous exclusion of these volumes until the compensatory regulatory mechanisms are overwhelmed and the intracranial pressure has increased. Next slide, John, please. So here we have a Lamb-Fitts curve. On it, we see the phase, and level of the purple line, we see the phase, the compensatory phase, in which the presence of the mass is not associated with an increase in intracranial pressure because the compensatory mechanisms are there. But at the point of the compensation, when these compensatory mechanisms are overwhelmed, the intracranial pressure starts rising until herniation occurs at around 60 to 70 millimeters of mercury of intracranial pressure. Next slide, please, John. So when this herniation occurs, as you said, it is the passage of brain tissue through openings, be the openings of the skull or the spaces left at the level of the jural folds. So when this herniation occurs, we have consequences. They can be neurovascular consequences, so nerve compression, especially cranial nerve number 3 or cranial nerve number 6. You can have vascular consequences with arterial compression. Here we're talking about the branches of the carotid arteries, be the anterior, middle, or posterior cerebral arteries, anterior, middle, posterior cerebral arteries, and the resultant cerebral infarction. You can have parenchymal consequences due to the compression of the brain tissue by the protruding, the compression of the brain tissue by the protruding portion of the brain tissue. So we can have compression of the white matter, which will give motor or sensory deficit. You can have cranial nerve nuclei at the level of the brainstem that are compressed, and vital centers that are compressed too. For example, in cases of cerebellar or tonsillar herniation. You can also have cerebrospinal fluid obstruction that can be associated to a hydrocephalus, which increases the intracranial pressure. So yes, next slide, John. So talking about the herniation syndrome proper, They can be caused by various types of lesions, either traumatic lesions, for example, in patients that sustain traumatic brain injury, tumoral lesions, vascular lesions, aneurysms, infectious lesions, or even congenital lesions, for example, Arnold Chiari malformation that we associated to a tonsillar lower the tonsils below the level of the foramen magnum. Next slide, please, John. So according to Plum and Posner, brain herniation can be classified from cranial to caudal into sub-5 falcine herniation, transalar or transsphenoidal herniation, transtentorial or uncal herniation, central or central transtentorial herniation, cerebellar tonsillar herniation, and transcalvarial herniation or extracalvarial herniation. Next slide, John. Talking about the subfalcine herniation, in this herniation, it is first of all the most common herniation found at the level of the brain imagery for patients that when we have suspicions of herniation. It includes the ipsilateral, the displacement of the ipsilateral, the displacement of the ipsilateral cingulate gyrus through the anterior falx, and it is generally due to a unilateral or ipsilateral hemispheric lesion. Next slide, John. So radiologically or at the level of the CT scan, it can be identified with a midline shift, so a syndrome blocker. They can be caused.
I might rewind sometimes because I'm taking notes.
Okay.
Yeah, and see, only if you need me to go back, let me
Certainly.
know.
Okay.
By various types of lesions, either traumatic lesions, for example, in patients that sustain traumatic brain injury, tumoral lesions, vascular lesions, aneurysms, infectious lesions, or even congenital lesions. For example, Arnold Chiari malformation that we associate to a tonsillar lowering of the tonsils below the level of the foramen magnum. Next slide, please, John. So according to Plum and Posner, brain herniation can be classified from cranial to caudal into sub-5 falcine herniation, transalar or transsphenoidal herniation, transtentorial or uncal herniation, central or central transtentorial herniation, cerebellar tonsillar herniation, and transcalvarial herniation or extracalvarial herniation. Next slide, John. Talking about the subfalcine herniation, in this herniation, it is first of all the most common herniation found at the level of the brain imagery for patients that we have suspicions of herniation. It includes the ipsilateral, the displacement of the ipsilateral, cingulate gyrus through the anterior falx, and it is generally due to a unilateral or ipsilateral hemispheric lesion. Next slide, John. So radiologically or at the level of the CT scan, it can be identified with a midline shift, so a line that is drawn most often anterior posteriorly in the position that should be occupied by the septum pellucidum. So if you have a shift of this midline towards the direction, especially at the level of the subfalcine area, we can suspect a subfalcine herniation. Besides that, we can have an asymmetry at the level of the anterior falx region with widened cerebrospinal fluid spaces on contralateral anterior falx. Like you can see on the diagram besides, we have you can see the four cerebri above the hyperdense line, and then we see that we have a displacement of the brain tissue just below this line with consequent compression of the ventricular spaces ipsilateral to the lesion, and we see a widening of the cerebrospinal fluid space to the right in the opposite direction to the compression. Next slide, John. So subfalcine herniation can be associated to some complications, notably contralateral hydrocephalus due to the obstruction of foramen of Monro. As we said, it can be associated to a compression of this ventricular space, and an anterior cerebral artery territory infarction due to the compression of the anterior cerebral artery branches that pass through that region. Next slide, John. So next, we're talking about the transalar herniation or transsphenoidal herniation. So it is a not very frequent type of herniation. It concerns herniation of the brain matter in and around the middle fossa across the greater sphenoidal wing. So it occurs usually in combination with subfalcine and transtentorial herniation, and can either be descending or ascending, respectively, in cases of frontal lobe mass effect or middle cranial fossa or temporal lobe mass effect. Other complications include mid-cerebral artery territory infarction or anterior cerebral artery territory infarction, or both of them, depending on the direction in which the displacement of the brain tissue occurs. Next slide, John. So talking about the transtentorial uncal herniation, which concerns the herniation of the uncus, here we see on the diagram besides with the D, the labeling D, which represents the uncal herniation. So it concerns the displacement of the hypocampal iris through the lateral border of the tentorial incisura. It results in a compression of the ipsilateral cerebral peduncle, knowing that part of the pyramidal tract goes through that cerebral peduncle, a compression of the posterior cerebral artery, which is possible, but not very frequent, and a compression of cranial nerve number 3. So among the clinical manifestation, we have an ipsilateral dilated pupil. You can have a hemiparesis that will either be ipsilateral or contralateral, depending on whether it is the ipsilateral cerebral peduncle that is compressed, in which case the hemiparesis will be contralateral, or it is a contralateral part of the brain tissue that is compressed against the lateral body of the incisura, and in which case we give an ipsilateral hemiparesis, also known as Kenohan phenomenon. Next slide, John. So here we see a patient having sustained traumatic brain injury to the left. Other complications include mid-cerebral artery territory infarction or anterior cerebral artery territory infarction, or both of them, depending on the direction in which the displacement of the brain tissue occurs. Next slide, John. So talking about the transtentorial uncal herniation, which concerns the herniation of the uncus, here we see it on the diagram besides with the T, the labeling D, which represents the uncal herniation. So it concerns the displacement of the hypocampal iris through the lateral border of the tentorial incisura. It results in a compression of the ipsilateral cerebral peduncle, knowing that part of the pyramidal tract goes through that cerebral peduncle, a compression of the posterior cerebral artery, which is possible, but not very frequent, and a compression of cranial nerve number 3. So among the clinical manifestation, we have an ipsilateral dilated pupil. We can have a hemiparesis that will either be ipsilateral or contralateral, depending on whether it is the ipsilateral cerebral peduncle that is compressed, in which case the hemiparesis will be contralateral, or it is a contralateral part of the brain tissue that is compressed against the lateral border of the incisura, and in which case we give an ipsilateral hemiparesis, also known as Kenohan phenomenon. Next slide, John. So here we see a patient having sustained traumatic brain injury to the left, and we see the anisocoria that the patient presents. On the one side, to the right, we have a tight pupil, and to the left, we have a relatively normally sized or little dilated pupil. So, and on the right image, we have a completely dilated, widely dilated pupil, which in this case will be indicative, especially if associated to hemiparesis, will be indicative of an uncal herniation. Next slide, John.
Hold on, I'm having a little hard time here. I'm having my own technical difficulties.
Okay.
Hold on. Okay, there we go. Hold on, I'm sorry about this. Okay, tell me which slide is next one.
No, go back. I think 2 slides behind. Again, another slide. Okay, next slide.
Back or forward?
Forward. Okay, so after the transtentorial uncal herniation, we have the transtentorial central herniation. Here it's about the displacement of the diencephalon through the tentorial incisura, and it's most often related to bilateral hemispheric expanding lesions that cause equal compression on both sides and displacement of the diencephalon through the tentorial incisura medially. So clinical manifestations can include altered consciousness, tired pupil, abnormal respiratory rate with change stop respiration. Next slide, John. Talking about the tonsillar herniation or the cerebellar herniation, in this case, it's mostly a cerebellar herniation. It concerns the descent of the cerebellar tonsils below the level of the foramen magnum. So it's sometimes termed coning. When it occurs, it's termed coning. And as we know, the brain stem, which is just passing through the foramen magnum, contains the major life-supporting centers, be it the respiratory or the cardiovascular centers. So as this occurs, we have a subsequent compression of the brainstem against the borders of the foramen magnum. And the consequences, as we see, the compression of the brainstem against the clivus, on the one side, with consequent compression of the life-supporting centers, and you can have either respiratory arrest, or we have compression of the vertebral arteries. As we know, the vertebral arteries pass at the level of the foramen magnum too. So compression of these vertebral arteries leads to massive bilateral cerebral infarction that can lead to immediate death in the patient. So this one particularly is an emergency. Next slide, John. So at the level of the compression of the brainstem against the clivus, on the one side, with next slide, John. Talking about the tonsillar herniation or the cerebellar herniation, in this case, it's mostly a cerebellar herniation. It concerns the descent of the cerebellar tonsils below the level of the foramen magnum. So it's sometimes termed coning. When it occurs, it's termed coning. And as we know, the brain stem, which is just passing through the foramen magnum, contains the major life-supporting centers, be it the respiratory or the cardiovascular centers. So As this occurs, we have a subsequent compression of the brainstem against the borders of the foramen magnum, and the consequences, as we see, the compression of the brainstem against the clivus, on the one side, with consequent compression of the life supporting centers, and you can have either respiratory arrest, or we have compression of the vertebral arteries. As we know, the vertebral arteries pass at the level of the foramen magnum too. So compression of these vertebral arteries leads to massive bilateral cerebral infarction that can lead to immediate death in the patient. So this one particularly is an emergency. Next slide, John. So a lot of the CT scan, we see here to the right, we see a brain with an MRI. We see a brain that has really important cerebral edema, and that edema is really very pronounced at the level of the posterior cerebral fossa. So we have an effacement of cerebrospinal fluid system surrounding the brainstem, which is a sign of tonsillar herniation. And besides, we can have an inferior descent of the cerebral tonsils below the level of the foramen magnum, which we see clearly at the level of the image, the MRI to the right. We see the descent, and even the brainstem that goes a little bit lower, and we have its compression at the level of the foramen magnum. Next slide, Johnny. We also have extracalvarial herniation. In this case, it is the herniation of the brain tissue external to the calvaria through a bone defect at the level of the skull. Either it is post-traumatic bone defect or a post-surgical bone defect. So in this case, it is different from encephalic cells in that it is not surrounded by meninges, so it is not a malformation. It is an acquired lesion, either following a surgical procedure, for example, decompressive craniotomy, or following a head trauma. Next slide, John. So concerning the management of cerebral herniation, the management has to be engaged upon recognition of the clinical condition. So immediately upon recognition of the engagement, especially if it's an acute herniation, upon recognition of the herniation, management has to be instituted. And the immediate goals in a way for etiologic treatment, the immediate goals include reduction of the intracranial pressure while maintaining cerebral perfusion pressure and oxygenation, which is very important, as we know that the brain is a matter of blood perfusion and oxygenation. Second, prevention of secondary injury, amongst which you have hypercarbia and acidosis. The means for the management for the obtention of these immediate goals include the blood pressure management for cerebral perfusion pressure, controlled ventilation for oxygenation, and intravenous infusion of mannitol for reduction of intracranial pressure. All these measures are immediate measures, especially in the acute herniation syndromes, and are used to allow the brain to accommodate the underlying lesion in a way for etiologic, for definitive diagnosis and etiologic treatment. In this case, we're talking about if it is, for example, a brain trauma, in a way for a surgical procedure, either burr holes or craniotomy, depending on the cause of the brain herniation. Next slide, John. So the methods for the obtention of these immediate goals, as we said, we have reduction of intracranial pressure, maintenance of cerebral perfusion pressure, and oxygenation. So first, initial resuscitation. Here it's mainly applied to acute cerebral herniation syndromes. So first, we have to ensure airway, and have a proper airway has to be ensured, especially if need be, intubation should be considered with 100% oxygenation. Hyperventilation can be used with partial pressure in carbon dioxide brought to the level of 30 to 35 millimeters of mercury, and it is accepted by the Brain Trauma Foundation and the American Association of Neurological Surgeons in cases of expanding hematomas causing transtentorial herniation. So we have to know that it is a dangerous procedure to some extent because it can be associated to cerebral ischemia, so it should be used with some degree of precaution. Circulation and blood pressure monitoring in order to maintain cerebral perfusion pressure. Then besides the initial resuscitation, we have intravenous infusion of mannitol, which unless in cases of hemorrhagic shock, the recommended dosage for intravenous infusion of mannitol is a bolus of 1 to 1.5 gram per kilogram of body weight of money.
At this level, I wouldn't worry too much about the doses or the specifics, just really know big picture that brain herniation can lead to elevated ICP, and we need to treat the ICP in order to prevent secondary causes or secondary brain injury. And some of the big ways to treat elevated ICP is, first things we can do at bedside is hyperventilation, which means getting the individuals to blow off CO2 because that's been shown to reduce ICP, and then helping with brain swelling by giving the patient elevated or high osmotic solutions to help draw out water from the brain in order to decrease the intracranial pressure. So I think just knowing big pictures and not really getting into the details because that's, you know, at the resident level, and that's more so for neurologists. But just knowing big picture, because I do remember them asking, you know, the basics on the step 1, step 2, step 3 exam. Especially what they like to ask is the herniation syndromes. And what I remember is they'll give you a patient scenario, and then they'll ask which of the following herniation syndromes is most likely seen in this patient. So
Playing from Windows Q4 J80.
they'll give you a prompt. So that's where I would kind of focus the attention on. Now, I don't know if the testing is different in Jamaica, but at least in the US, that's where they like to ask questions.
Okay. Sounds more or less similar to what happens here. Yeah.
Cool.
And then besides this measure,
But I am glad to be able to come across this lecture, and it's showcasing African neurosurgeons who are presenting this data. So that's inspirational for me as a Black woman neurologist. Can you hear me?
Yes, hearing you.
Okay, cool.
measures, we have the subsequent etiologic treatment in order to remove the underlying lesion that causes the herniation. So concerning the prognosis of this patient, we have overall the prognosis is poor but not hopeless. For example, functional recovery can be quite good, especially when we have young patients who exhibited reversal of the clinical herniation signs when they received monitor and hyperventilation, and who have a removable intracranial lesion. Besides that, we have the mortality is quite high in cases of transtentorial lesions, transtentorial herniations, and also following traumatic herniation, traumatic brain injury or traumatic herniation, age is a profoundly negatively impacting factor. So the older the patient, the more the prognosis is really poor. And then in cases of non-traumatic cerebral herniation, we can have a good functional recovery for those patients, especially their young patients. Next slide, John. So here we have a visual abstract that was published a few months ago that discusses the efficiency of the common physical examination signs that we have for the detection of raised intracranial pressure, and compares them to invasive intracranial pressure monitoring measures. And overall, it tends to show that we have a really very poor accuracy in detection of elevated intracranial pressure as when these measures are used. So they recommend that in case of high suspicion of raised intracranial pressure, the patient will transfer to intracranial pressure to a center which can afford intracranial pressure monitor placement. So it was like a question, knowing that we have all of these strategies for low and middle income countries that we use, especially clinical measures for detection of raised intracranial pressure. So it really brings up the question of what then, in terms of low and middle income countries, for the detection of this raised intracranial pressure and subsequently prevention of cerebral herniation. Next slide, John. Okay, thank you for your kind attention. Yeah.
Oh, excellent, excellent, Dylan. Thank you for facing the technological problems and getting through a great presentation. So we'll open it up to any comments for the panelists.
That was really good.
Yes, for the most part, I think it was good. Some parts, you know, a lot to look over.
Sorry, for whatever reason, when I share a screen and listen to a listen to like a audio, it kicks off the audio from Zoom. So then I'm not able to hear you sometimes. So I have to like toggle it back and forth so that I can hear you. But I can hear you now.
Okay.
What do you think?
Yeah, I think that was a very good video, something to really learn from. It mimics a lot of the principles I would have been taught here. But definitely stuff I need to go over.
Yeah, and I think that's, you know, for me, it's the same thing. You know, I've heard this stuff before, but, you know, being able to go over it again and again and again, and then talk it out with other learners, that's how I learn best. So I'm going to share this in the chat so that you have it as well.
Okay.
Let's see. This might be a good one to look.
Continue.
It's like, let's see, intracranial mass, brain herniation. Oh, let's check this one out.
That one's different, yeah.
And this is more so like the radiology aspects. And then what I'll do, if they have good imaging, I'll pause it and then we can practice reading it
Okay.
together. Cool.
We continue with neurologic imaging. In this short lecture, let's talk about intracranial mass effect and brain herniation. So when you approach a HCT, rather than going into detailed neuroanatomy, I think a reasonable approach is to focus on several key levels.
Oh, so you see the name of this physician? I have listened to a lot of his lectures online. He's really good.
Who's this?
It's James. I
Oh.
can't say his last name, but if you look at the bottom of the screen,
Yeah, I'm seeing it.
yeah, he's really good. I've come across this stuff a lot.
This is especially important for acute HCT. The four levels that I like you to focus on, from inferior to superior, is foramen magnum.
Can you hear the speakers?
Yes.
Cool.
brainstem, basal ganglia, and motor ventricle. When you inspect each axial view, make sure to compare side to side. Symmetry is important. What's on the left should look like what's on the right. Make sure you look all around. When you look all around, make sure you inspect all the sulci, that they are patent, they are not being compressed. Look at all the CSF spaces such as cistern and the ventricle.
So what he's doing now is he is helping, and that's actually a really good idea. He is helping to come up, or he's actually describing a way to systematically read CT scans. Because what tends to happen is, let's say, you're in the emergency room, you're getting called. Well, I'll speak from a neurology standpoint. So, we'll be in the emergency room. We have like 10 patients that we have to see, and all of them have CT scans. And yes, the radiologist also reads it and confirms it. But for neurologists, it's important for us to be able to look at our own scans and be able to come up, with, some kind of differential, and then run it by the radiologist to see what they think. Because sometimes you got to act quick.
Right.
So one thing that I've learned in anything that you do in medicine, you always want to have a systemic way of doing it at the same time every time, because then it prevents you from missing things. So, when you're reading chest scan, look for a way to read every single chest scan the exact same way, because, you won't miss things.
Less likely to.
Yeah, you're right. Less likely. You can still miss things because we're all human, but you're less likely to if you read it every single time the same way. And then it, gets in a good habit. So I've been trying to find a good way for me to read CT scans. And this looks like a really good one. So let's see what, I'm going to slow this one down because this one is not too long. And I think it's going to be high yield.
We continue with neurologic imaging. In this short lecture, let's talk about intracranial mass effect and brain herniation. So when you approach a HCT, rather than going into detailed neuroanatomy, I think a reasonable approach is to focus on several key levels. This is especially important for acute HCT. The four levels that I like you to focus on, from inferior to superior, is foramen magnum, brainstem, basal ganglia, and motor ventricle. When you inspect each axial view, make sure to compare side to side. Symmetry is important. What's on the left should look like what's on the right. Make sure you look all around. When you look all around, make sure you inspect all the sulci, that they are patent, they are not being compressed. Look at all the CSF spaces such as cistern and the ventricles. When you look all around, make sure you inspect the right method differentiation, make sure they are preserved. Let's start with the lowest level at the foramen magnum. At this level, you should be able to see centrally a soft
soft tissue density spinal cord, which is surrounded by relatively hypodense CSF. If you see foramen magnums filled with soft tissue density in an acute setting, you are probably seeing acute tonsil herniation. One level above at the level of brainstem, specific by relatively hypodense CSF. If you see foramen magnums filled with soft tissue density in an acute setting, you are probably seeing acute tonsil herniation. One level above at the level of brainstem. Specifically, here is at the lowest level at the foramen magnum. At this level, you should be able to see centrally a soft tissue density spinal cord, which is surrounded by relatively hypodense CSF. If you see foramen magnums filled with soft tissue density in an acute setting, you are probably seeing acute tonsil herniation. One level above at the level of brainstem. Specifically, here is at the level of midbrain. On the axial view, midbrain looks like a Mickey Mouse, and the ear of the Mickey Mouse is crus cerebri or cerebral peduncle. Anterior to the Mickey Mouse, you will see a very important star-shaped cistern, suprasellar cistern. You want to make sure that it is widely patent. Posterior to the Mickey Mouse, you should be able to see a smile-shaped quadrigeminal cistern and ambient cistern. The quadrigeminal plate cistern is a flat portion. The corner of the smile is ambient cistern. Again, you want to make sure that they are open, not being compressed. The fourth ventricle. To the side, the medial portion of the temporal lobe, you should be able to see small temporal horn. Recall, temporal horn is the most dependent portion of the lateral ventricle. So you want to make sure that they are symmetric and they are not dilated. One level above at the basal ganglia. Again, you should be able to see the smiley, quadrigeminal, and ambient cistern. The lateral ventricles are small and are relatively symmetric. Through the foramen row, you will see third ventricle. Here on the axial view, third ventricle looks like a small straight line, and it should be right in the midline. Basal ganglia such as caudate head, lentival nuclei. Medially, you have lobus pallidus. Laterally, you have putamen and thalamus, separated by internal capsule. One level above, at the level of lateral ventricle, the lateral ventricles should be symmetric in size. If you draw a line down the middle, at the free attachment point of falx cerebri, the lateral ventricle should stay at the midline. You should be able to see caudate nucleus very well. So those are the key levels that I like you to focus on every single head CT. When assessed, you should be able to see caudate nucleus very well. So those are the key levels that I like you to focus on. So at the free attachment point of falx cerebri, the lateral ventricle should stay at the midline. You should be able to see caudate nucleus very well. So those are the key levels that I like you to focus on every single head attachment point of falx cerebri. The lateral ventricle should stay at the midline. You should be able to see caudate nucleus very well. So those are the key levels that I like you to focus on every single head CT. When a sagittal view is provided, make sure you inspect at the level of foramen magnum. If you draw a line from the under edge of the foramen magnum, the cerebellar tonsils should be positioned above the foramen magnum. Also, you should be able to see a nice, small cerebral aqueduct. That's a passage point between third ventricle into fourth ventricle. And the fourth ventricle should look like a small, nice triangle on the sagittal view. So what do you look for in terms of intracranial mass effect? One of the major clues that there is potentially a large intracranial mass effect is focal effacement. Another strong clue is shifting of the midline structure. Then let's go over some of the major brain herniation patterns that we all need to recognize. In this example, if you look at the left hemisphere, you can see multiple cells.
Sion, would you like to read this CT scan?
Sure, I could try. So this looks like a CT, non-contrast CT scan of a patient's head, projecting as an axial view. To comment on the right side of the head, I see a hyperdense collection, or could be blood. A midline shift to the left side, or sorry, hold on, all right, to the right side, hold on, yeah, to the left, right. So a midline shift to the right, to the left, sorry, with the mass effect and some amount of cerebral edema, marked by, not being able to appreciate the sulci and gyri.
Very
Yeah.
good. Very good. Yeah, I agree with you. CT head without contrast, axial cut of the brain. We're at the level of the lateral ventricle. On the right side, there is hyperdense region that is what we call crescent shape. That's pathognomonic for what?
I think that would most likely be a subdural hematoma, or not an epidural, subdural.
Yeah, very good. And because the this hyper dense, it's probably in the acute setting, because then what happens over time when the blood reabsorbs, it'll become more hypodense.
Right.
And we see that a lot in individuals that have like chronic subdural hematomas. So I agree. We have acute subdural hematoma with evidence of midline shift. So let's see, it'll be hard to calculate how much because this doesn't show centimeters, but like he said, what you do is you take a straight line from the anterior pole to the posterior pole of the skull. You want to match it up with the false cerebri, and what should be along there is one side should have the lateral ventricle, the other side should have the lateral ventricle, and the septum pellucidum should align with that initial straight line. And the shift that we're looking for is how far is the septum pellucidum away from the actual perpendicular, of the actual vertical line from the anterior pole to the posterior pole. And then that gives us centimeters. And the greater the shift, the worse the herniation is. Ooh, so here's another question. What kind of based upon our herniation discussion, what kind of herniation do you think this would be? If it has a midline shift, what's that associated with?
With midline shift, you could have a subfalcine herniation.
Very good. And then what was one of the complications of a subfalcine herniation that they mentioned?
I don't remember now.
It's all good. Let me show you. So I won't be able to show you, sorry. So they talked about, so around here, around this region, one of the presenters had the circle of Willis that overlays this area. And let me just pull up a picture. Of the circle of Willis.
Sorry.
Oops. So he had taken one of the blood vessels and he overlaid it on top of the.
Yeah, I remember that part.
Yeah, and so they said that the anterior cerebral arteries, tend to get compressed.
Okay.
Because if you look, I'm trying to find a good image for us. So if you look here, let me just get my fancy annotating tool. So this is where the false cerebri would be, and if we have a subfalcine herniation that's pressing on the false cerebri, what blood vessels feed the medial frontal lobes?
The anterior cerebral.
Exactly. So that's why they say that the anterior cerebral artery is, more commonly to be affected and then lead to
Right.
ischemic changes in the individual that has midline shift, which that just clicked for me today. I had no idea until we discussed it today. So that's cool. Great job. What else? Let me just clear that. So yeah, so we talked about midline shift, mass effect, increased ICP, and then here he's going to talk about the sulci, which are, they call it sulcal effacement, which are pretty much gone because there's just so much swelling in this brain, and this is not good. Cool, great job.
Okay. That are widely patent. Those spaces are filled with CSF, so they should be relatively hypodense, just like CSF within the ventricle. Compare that to the right side. You will see that on the right, the sulci are effaced. They are not well seen. So when you see that, you should suspect there's a diffuse mass effect from the right side. In this case, you can also see the right outer ventricle is more compressed compared to the left side. Another major clue is shifting of the midline structure. In this case, if you draw a line down the middle, you can see that at the level of septum pellucidum, indicated by the yellow arrow, there is a shifting of the septum pellucidum from right to left, indicating a mass effect from the right side. When you see one of those findings, you should have high index suspicion for a diffuse large intracranial mass effect. In this case, the culprit is a hyperdense or acute subdural hematoma. Let's look at some of the major brain herniation patterns. In this cartoon, you see that there is a large epidural hematoma generating a large left-sided intracranial mass. There are multiple different patterns of brain herniation. I like to focus on three major patterns that I think everybody should be able to recognize. One is subfalcine herniation, so brain structures herniating across underneath the falx. Another one is uncal herniation or transtentorial herniation. In this case, you have a ipsilateral left-sided uncal herniation. So the uncus, which is the medial part of the temporal lobe, is herniated medially and under the tentorium. If the mass effect is diffuse, involving both sides, bilateral cerebral hemispheres, you can have bilateral uncal herniation, also referred to central herniation. Lastly, if you have a mass effect within posterior fossa, you can push cerebral tonsil below the level of foramen magnum, causing crowding at the cranial cervical junction, tonsil herniation. So let's look at an example of subfalcine herniation. Cranial cervical junction, tonsil herniation. Medially and under the tentorium. If the mass effect is diffuse, involving both sides, bilateral cerebral hemispheres, you can have bilateral uncal herniation, also referred to central herniation. Lastly, if you have a mass effect within posterior fossa, you can push cerebral tonsil below the level of foramen magnum, causing crowding at the cranial cervical junction, tonsil herniation. So let's look at an example of subpulsing herniation. In this example, 3 key images. I'd like you to focus on the middle image and the image to your right. At the level of basal ganglia, if you draw a line down the middle, you can see that the septum pellucidum has been shifted from left to right. When you see that, you should have high index suspicion that there is some large mass effect from the left side. In this case, there is an isodense subdural hematoma. This type of subdural hematoma is the most difficult to detect in that they are isodense to the brain parenchyma. So in other words, there's very little contrast between the pathology itself and the brain parenchyma. So if you don't notice that mass effect, you can potentially miss this very significant pathology. At the level of lateral ventricle, you can see at the free attachment point of Fox, there is a left to right subpulsing herniation. So what are the complications for subpulsing herniation? One, you can obstruct the CSF outlet at the level of foramen Monro. Recall foramen Monro is the passage between lateral ventricle and the third ventricle. If you have a large subpulsing herniation, as in this case, a large left to right midline shift, usually you will see there's obstruction at the foramen Monro, causing contralateral dilatation of the lateral ventricle and ipsilateral compression of the left lateral ventricle. Another potential complication is ACA infarction. When you look at this diagram, notice the relationship between Fox cerebri and the adjacent ACA. So if there is a large subpulsing herniation, you can imagine there's a potential that ACA can be compressed. This is an example of a MRI T2-weighted image. You have a ACA that's outlined by the yellow arrow, is that black dot and the curved line. They should be in the middle example of subpulsing herniation. In this example, 3 key images. I'd like you to focus on the middle image and the image to your right. At the level of basal ganglia, if you draw a line down the middle, you can see that the septum pellucidum has been shifted from left to right. When you see that, you should have high index suspicion that there is some large mass effect from the left side. In this case, there is an isodense subdural hematoma. This type of subdural hematoma is the most difficult to detect in that they are isodense to the brain parenchyma. So in other words, there's very little contrast between the pathology itself and the brain parenchyma. So if you don't notice that mass effect, you can potentially miss this very significant pathology. At the level of lateral ventricle, you can see at the free attachment point of Fox, there is a left to right subpulsing herniation. So what are the complications for subpulsing herniation? One, you can obstruct the CSF outlet at the level of foramen Monro. Recall foramen Monro is the passage between lateral ventricle and the third ventricle. If you have a large subpulsing herniation, as in this case, a large left to right midline shift, usually you will see there's obstruction at the foramen Monro, causing contralateral dilatation of the lateral ventricle and ipsilateral compression of the left lateral ventricle. Another potential complication is ACA infarction. When you look at this diagram, notice the relationship between Fox cerebri and the adjacent ACA. So if there is a large subpulsing herniation, you can imagine there's a potential that ACA can be compressed. This is an example of a MRI T2-weighted image. You have a ACA that's outlined by the yellow arrow, is that black dot and the curved line. They should be in the midline normally. Because of the left to right midline shift, there's a shifting of the ACA to the right, potentially causing compression of ACA. Here's an example of a patient with a right to left subpulsing herniation with a resultant right-sided ACA territory infarction. Or uncle herniation. This is the same patient we just see with a left to right midline shift. Sometimes the uncle herniation can be very, very subtle, as in this case. So your index of suspicion should be high. At the level of brainstem or the midbrain, recall you should be able to see a nice star-shaped cistern, suprasellar cistern. That should be widely patent. In this case, you can see the left ungus, the medial portion of the temporal lobe, is just slightly more medialized compared to the right side. So here you have a subtle or early uncle herniation. Sometimes the finding is not subtle. This is another patient with acute trauma. You can see there's a large right-sided temporal hemorrhagic contusion. On day 0, the suprasellar cistern and the spine-shaped quadrigeminal cistern and ambient cistern remains patent. So at this point, you do not have an uncle herniation. 2 days later, you can see there are multiple hemorrhagic contusions since development, including the left side. Look at the level of suprasellar cistern. You can see the ungus bilaterally are much more medialized compared to day 0. And you can also see the star-shaped cistern, suprasellar cistern, is much more compressed. The quadrigeminal cistern and the ambient cistern are also not well seen. They are also much more compressed compared to day 0. So at day 2, you have central herniation or bilateral uncle herniation. So what are the potential complications for transtentorial herniation? Well, one of the early symptoms may be third nerve palsy. If you look at the diagram, notice the ungus and the third nerve. So in this case, if you have medialization or uncle herniation, there's a potential that you can compress on the third nerve. Another thing that you may see is one of the early symptoms may be third nerve palsy. If you look at the diagram, notice the ungus and the third nerve. So in this case, if you have medialization or uncle herniation, there's a potential that you can compress on the third nerve. Another thing that you may see is weakness. It can be contralateral or sometimes ipsilateral. In this cartoon with a large left-sided epidural hematoma and left uncle herniation. The uncle herniation can cause compression on the midbrain, causes compression on the ipsilateral corticospinal tract, therefore causing a contralateral weakness. Just like the phenomenon with stroke. If you have a left side stroke, causes right side weakness, it's the same idea. Once in a while, you can have a mass effect that is very significant, causing shifting of the midbrain from left to right. And the midbrain can impinge on the right side of tentorium, cause a physical notch. That's a Kernahan's notch phenomenon. In this case, you can have compression of the contralateral corticospinal tract, therefore causes ipsilateral weakness. So the weakness can be contralateral or ipsilateral. Another potential complication is PCA infarction. In this diagram, you can appreciate the relationship between ungus and the adjacent PCA. So if you have an uncle herniation, there's a chance that you can have a mass effect against the PCA, causes a PCA infarction. This is an example of somebody with a right-sided uncle herniation, causes right-sided PCA infarction. Lastly, let's talk about tonsil herniation. In this case, at the level of midbrain, you can see that there is bilateral cerebellar tonsil herniation causing effacement of the suprasellar cistern the star-shaped cistern, and the quadrigeminal plate cistern. So there is central herniation. That mass effect also translates into a large mass effect within posterior fossa. So at the level of foramen magnum, you can see that entire foramen magnum is filled with soft tissue density. Compare that to a normal patient. You can see in a normal case, at the level of foramen magnum, there is hypodense CSF surrounding the upper spinal cord. In our patient, the entire foramen magnum is filled with a soft tissue density consistent with tonsil herniation. When you suspect tonsil herniation, you should ask for a sagittal reconstruction. For a normal patient, again, the cerebellar tonsils should be positioned above the foramen magnum. In our patient, you can see the tonsil is herniated below the level of foramen magnum, and there's diffuse crowding at the craniocervical junction. CSF has no place to go. This is another case with a large posterior fossa lesion in a pediatric patient. There is a mass effect, causes a tonsil herniation, and crowding at the craniocervical junction causes obstruction of the lateral ventricle and the fourth ventricle, so obstructive hydrocephalus. Also in acute setting, if you have acute compression of brainstem, you can cause respiratory or cardiac failure. Those are some of the potential complications for the major brain herniation patterns, things that we all need to recognize on PET-CT. If you have any questions and comments, please email me.
Do you have any questions? Oh, hold on 1 second. Yeah. Let me change my speakers again. You have any questions?
No questions. Yeah, no questions.
Awesome. I think we did a very thorough job of reading, learning, listening, discussing brain herniations. Sounds like the major ones to know are 3: subthalcine, uncle herniation, and tonsillar herniation. And then there's no different complications associated with that. And I think the next step, and once mastering that, is, well, you know, what do you do from ICP management? But I think, you know, that's more so upper level when you're an intern, et cetera. But I think at this stage, just knowing the 3 herniations, how to recognize them, and then what are some of their complications. So you can, if you do that, then I think you're off to a phenomenal start, which sounds like you already have a master of it, and just being able to identify it on, you know, a CT scan.
Right. Okay.
Cool. So I think tomorrow, the schedule, trying to get us back on schedule. Let me see. Give me 1 second. I think our schedule for tomorrow is tomorrow's the 1st. Oh, that's when we get to do some test questions, but we haven't been able to get to all of the topics yet. So we still have meningitis and encephalitis next. And then we still have to cover AIDP, CIDP, and then muscular emergencies. So I think the next one we can talk about tomorrow is what do you want? Do you want to do, do you want to do AIDP, CIDP, or do you want to do neuromuscular emergencies?
I don't know what AIDP is actually.
Oh, sorry, I wasn't able to hear you.
I wasn't sure what AIDP was or CIDP.
Oh, sorry, it's Guillain-Barré.
I'm so,
Syndrome.
oh, okay. I think it's whichever best suits your schedule. I think that works with me.
Let's do let's do Guillain-Barré, AIDP, CIDP. So basically acute inflammatory demyelinating polyreticular neuropathy. I think that's what
Okay.
that stands for. Let me Google that real quick.
Yeah, acute inflammatory demyelinating polyneuropathy.
Awesome. So, if you have, again, there's no prep work. We'll do what we did again today. Listen to some podcasts. Maybe if I can find a good review paper, we can go through that. And then maybe listen to some videos and then, do questions back and forth.
Okay.
Cool. Awesome.
Hey,
Great job.
great.
Thanks for hanging out with me and studying with me.
No problem. Could you pronounce your first name for me, please? So it's
Esiosa.
Esiosa. Okay. Perfect.
Awesome. Thank you so much, Sion.
All right. Thank you, Dr. Esiosa. I guess I'll see you tomorrow. I'll talk tomorrow.
Yeah.
All right. Have a good night.
You too.